Welcome everybody to this lecture. We talk about the indication to do veneers. We need to know exactly when we can use this kind of technique. Frankly speaking, I could say that many friends said to me, I have no cases in which I could really utilize the veneers technique. But I don't believe it is true. We have a lot of cases that can be able to be treated this way. So let me talk about the indication at this point. Showing some cases like wear on the incisal ledge, like on the bottom on the right side, or cuspid in the lateral incisal position, for example. Both cases are something that can be used. So, other case, diastemas, and again, cuspids on the lateral incisal position. Or this case, like having big restorations and a lot of composites that are more or less kind of, combination between composites, between natural dentition, and I believe that is another case that can be used. Colors can be changed, or even wear, incisal wear. Of course, we have to take really care about it. We have to be very careful, but that's another case that can be obtained or can be used veneers. So let me go step by step and let me show you what are the cases in which I can use veneers. First of all, how to modify the arrangement, how they are positioned, especially in the lower arch and the lowers, for example, that most of the time they are, overimpose each other. And so that is very important that can be maybe change the arrangement in some way. Secondly, how to modify shape and contour. So the form, the shape of the teeth can be increased, can be reduced, mostly increased normally, the volume. How to modify the color. So that can be used also. We can modify the color, even though can be an indication, but also a contraindication. If you use a very classic and normal kind of veneer with a very minimal thickness, you cannot cover the color underneath. It will be dark anyway. It will be not good anyway. So it will be combination and indication. I will show you later a case that is quite nice to understand. And then a fracture of the main core. So the coronal fracture, shortening the teeth completely because you have a kind of an accident, for example. That is the way how to really restore with veneers. Then, worn dentition. As I already anticipated to you, in some cases, you can also use veneers even though you have worn teeth in front of you. Of course, you have to consider the entire mouth, you have to consider the entire picture of the patient and understand exactly if you can limit your restorations up to the upper anteriors, or if you have to extend to all mouth. That is another story. And then extended composite restoration. I'm meaning about when you have the composite, the third class interproximally, going from the buccal to the lingual. That is always very interesting that if you can keep this kind of restoration composite on the interproximal area, covered or uncovered by the veneer. That is another interesting option. And last but not least, also to be used as a kind of occlusal optimization. That means when you have the chance to see that you have no contact on anteriors, for example, and you want to do a kind of palatal veneer of the upper jaw anteriorly in order to optimize the aesthetic result, the aesthetic stability on anteriors. So let me start with this. Of course, another case that can be considered an indication but also a contraindication. So arrangement modification, that is an arrangement that we don't like it at the patient age. So she cannot really continue to go ahead like that. She doesn't like it at all. She want to modify, but that is very complicated case. And to be honest, that is not an ideal case in any way. The only ideal case should be that to do orthodontics as first step, and then maybe to do some restorative. But of course, the ortho is a must in this case. But you know what happened. Many patients doesn't want to go to ortho when they are not more a child. You know, she was on the 50s, and she want to improve the situation, but was not really able, was not intention to have an orthodontic treatment done. So we have to understand if you are able to accept a compromise or not. That's the point. And in this case, we decide after years of resistance, we try to avoid it. But then at the end, we decide to do it. We did that. Oh, geez, very complicated. What I've done. At this point, how can I insert any restoration in this way? We have undercuts, mesially and distally. But if you follow me, maybe you can understand that we can have a way to do it. Also with the help of one veneer. That's not the veneer, that is the crown. We devitalize the tooth, of course, we cannot have another chance. But then mesially, the lateral incisor create an undercut. And if you look closely, the distal part of the central incisor, I mean in the 21, so the left one, is really touching completely the lateral incisor. It means they are proximity there. So the teeth are going together. You know, they are going together and they have the teeth and the root proximity. So what you have to do at this point is the following. You can cut a little bit mesially. And at this point, mesially, we can go through this central incisor. That's not so bad, but you see that they have a big line vertically in the central part of the back side, and the patient wanted to do some restoration there. So we have a plan to do a veneer on the right central incisor now. But we can cut partially to have not undercuts on the mesial part. But distally, it will be very complicated if you don't do any kind of enamel adjustment. So we can have an enameloplastic procedure there to really reduce the enamel there. And not to be undenting, of course, at the end, but more or less to have the chance to reduce it. So we have to do a bevel preparation on the cervical area, on the distal part of the central incisor, between the central incisor and lateral incisor. We open the space over there, as you could see there, exactly this arrow. And we also, thanks to the preparation that we have done on the right central incisor, we have the part of the preparation that is partially in dentin, but all the rest is in enamel, especially the interproximal confine and finiture line that is completely in enamel, as you see here. So in this way, you have the ability probably to insert your crown, that again, remember, that was completely turned and inclined. We have the chance to devitalize the tooth, the left central incisor, and in this way to reduce the possibility to have undercuts between the central incisor on the right side and the lateral incisor on the left side. So now we can insert this crown, plus you will insert a veneer that will helping the crown to be positioned, because we have prepared, as you have seen, partially inside the body of the right central incisor. In this way, we have the ability to create a kind of possibility to insert the central incisor. So we see a crown on the left, a restoration that is a veneer on the right, and that's the result at the time of insertion. That means in the 90s, 95 maybe, something like that, or 92, I don't remember. So beginning of 90s. So we are happy because in some way, even though we know, of course, that is a compromise solution, but still we have the chance to realize something that was helpful and happy, nice for the patient, of course, that is the most important step, of course. We did it for the patient, that was 97. So at this point, we had the chance to follow the case 8 years later. Remember that we have proximity, so the two roots are together. You have no any bond between the lateral incisor, left lateral incisor, and the left central incisor. So between them we have proximity. So we expected since the beginning a kind of recession there. It was not normal to have it, but still the two central incisors now are perfectly aligned, and what the patient wanted is this. But I want to show you 23 years follow-up. At this point, even though you see the case altogether is not going so well because the patient doesn't show up for the oral hygiene recall for years and years, but you see that we have just a little recession on the left central incisor that are not visible because, as you can see on the right side, the smile line of the patient is a low smile line. So, still, 23 years after, I could say, even though we selected a compromise solution, we can be happy because the two teeth are still there without any problem, and not in bad situation, especially if you compare the other remaining teeth that are in the worst condition than before. So we obtain this kind of follow-up. We have changed completely the visibility of the patient. We have the help to do a crown with the compromise, with the veneer on the right side, the right central incisor that help the central incisor left side to be inserted because the undercuts were so high that without the veneer, we couldn't succeed 100%. That is the 23 years follow-up, and you can see that was a very big change in terms of final outcome. That is a case that was made only 2-3 years ago, so a very recent case. And the patient, again, need the orthodontic treatment. No story. That's the best solution for sure. We tried to force this young lady to do it, but she didn't want it. She didn't want to have any appliance, fixed appliance in place, and we decided to do some additional veneer in this case. Look at this, seems a rabbit, only the two central incisors visible. You see that we have increased the bulk of the two lateral incisors, and of course, looking at these two veneers on the lateral incisors seem to be crazy because they are not lateral incisor anymore. They seem to be like, I don't know, a flat area, big area, very large. But remember, the patient doesn't feel nothing strange because on the lingual part, on the palatal part of the two lateral incisor, she was the habit also before to feel the presence of the lateral incisor. But buccally, you are between the central and the cuspid that are more out, and the lateral incisor buccally are in line with the central and the cuspid. So the feeling of the patient was absolutely not bad, was normal. We have also added one on the bicuspid, one veneer on the bicuspid to realign completely the teeth. And what could say? That we obtained better result. We could say that is a nice result obtained, but of course, it's still more complicated to clean this area. So we have to learn the patient to clean perfectly and to check the patient that she's doing all the time this kind of cleaning procedure. That is very important to maintain the case over years. We had a good improvement also in terms of seeing also the lateral incisor, not just the central incisor, to be less rabbit, we could say. And you can see now the total, the full smile, that you see that the patient is showing a better view than before. Of course, is a much better view. So that's the veneers indication. Our arrangement was so poor at the beginning that we have added in this way some additional veneer. You obtain very nice result. Again, arrangement modification. Look at the lowers. That's a very, very often situation like that. We meet a lot of people. Among 100 people, probably, we have maybe 10%, I don't know, maybe even less, of people that are perfectly aligned teeth on the lower arch anteriorly. I don't believe more than 10%, really. And that's the reason why we believe that is still keeping some lateral or central incisor of the lower arch that are overlapped or underlapped can be still very acceptable because it's a very natural situation. And you can see how the teeth were before. Look at the cervical area, the cervical height. And you see that, for example, the central incisor of the right side on the lower arch was more in, and the cervical margin was higher level than the others. So theoretically, this tooth should be higher level also incisally. But the patient didn't want it, even though it was more natural. And the patient wanted to have the 6 anteriors completely at the same area. Of course, we obtain very nice result in terms of difference between before and after. I believe that the patient was very happy, but still, the right central incisor of the lower arch, the central incisor of the lower arch, seems to be more unnatural because it's not the same level of disease outline. In these cases, the position of the teeth is more in, and the incisor edge is more high. But the patient didn't like it. She liked it to have this kind of perfect situation, coming from this to this. And that is what the patient wanted, and we followed in this particular case the need of the patient. Even though we, of course, always try to commit the patient to follow our rules, of course. What to do in a case like this? And again, we cannot do without ortho. We do ortho much more today than before. We know that we can easily obtain better results, and we try to obtain better results before doing anything more. That was done orthodontically. We achieved an alignment, and then we did the veneers to close the holes, to close the space between the teeth. But again, we cannot do without ortho. In this case, it was a must. We came from this to this. We're ready to now finalize our veneers, buccal veneers from cuspid to cuspid. So now we have the alignment that seems to be nice because it's obtained moving the tooth more out, finding the space between the other teeth around it, and at this point we finalize the case prosthetically, restorative. Other case, even the case we can say, I could align perfectly 100%, like in this case, the initial situation seemed to be possible to, to align teeth 100%. But if you look at it, we didn't. We didn't. Why? Because I believe that in this way, the patient seems more natural. When he talks, it means he's more natural, more alive. We have a situation like this that are very complicated. Why? Because you have the cement enamel junction, and then you have a very cervical area that are very, very, deep and triangular. We have the exposition of the root, and it's complicated. You should maybe arrive with your preparation of veneers up to the CEJ, and then you can do some composite, or maybe you can cover everything. We selected the second option. I believe that is important in this case to put your veneer, to extend your veneer up to the cervical margin. We did it with the 6 anterior veneers, and we obtained a nice result comprehending all the cervical area, as you can see, extended up to the cervical area. And that was the final outcome. Seemed to be okay, but what is like more is many years later, you can say that 10 years later, we still are in good position. We had just a very little chipping on the incisor edge on the central incisor of the lower arch, right side. But actually, even with a very thin periodontal biotype, we had a chance to optimize the case completely. What about shape and contour? That's nice because, as you know, we have a lot of different kind of shape of the central incisor. For example, we have a square, ovoid, triangular. That's three of the most known contour and shape, but sometimes you want to modify. We can say, we can tell you, we have a cuspid or canine, and that is what is happened. Scusa, devo troncare per 2-3 secondi, riprendo da qui. So let me check now with you about what to do with the contour, with the shape of the teeth. In some cases, we need it, like in this case. we see that we have a diastemas, very triangular teeth, and some recession around it. So we try to really modify the contour. She has high smile line, so everything you do will be absolutely 100% visible, so be careful what you do it. And again, what you do in this case, we try to optimize the aesthetic result, closing the diastemas, and also, I could say, changing the shape. Very pointed, very high, very triangular. She didn't like it, we too, frankly speaking. We kept enamel everywhere except the cervical area where we have a recession already, but on the rest we had enamel, backup preparation for veneers, and that's how the veneers in place. Now in the mouth, so in the model and the mouth. We changed a little bit the color, improving the color. That was used for the feldspathic porcelain in this case. Lateral view. And you see the beginning situation. And then what you have done, you have increased the volume everywhere, cervically and incisally. We increased also the length of the teeth partially. You obtain better result. We close the holes between the teeth, the diastema. We optimize the central incisor proportions and also width. So we have seen some situation in which we start with triangular teeth and you want to change it in some way, obtain better result. Other cases like that, the patient was not happy about the square teeth, especially incisally. But if you close the diastema, also between the two central, it will be really square, completely square. It will be like a box. So she wanted to be rounded. We prepare an enamel again. We had to maintain a kind of cantilever on the left cuspid there. That was having the lateral incisor on the left side as cantilever. We explain, of course, that it's not the ideal case, but just to avoid to put an implant in this case, the patient didn't want to put an implant. So, on the rest, cuspid, lateral, central, enamel, we have started with the square teeth, and we try to be more ovoid, as the patient wanted, more rounded. She loved it. She believed that it's a more female design. Maybe it's true. Maybe it's okay. For her mouth, for the ladies, this was the ideal case. Differently, this is a lady with natural dentition, on the 30s, big lips, not natural, of course. At rest position, she